Rebonjour à tous. Nous allons redémarrer la session, espérant que vous avez bien mangé et qu'il n'y aura pas d'effet postprandial. D'accord, donc là, nous allons commencer par la cardiologie interventionnelle. Et pour cela, nous appelons le professeur Chérif Mboub. Professeur Mabouri, merci de nous rejoindre. Professeur Valentin.
Good evening, everyone. Welcome to the joint session between the Egyptian Society of Cardiology and our guest faculty from different countries in Africa. Again, we are delighted that we are hosting you today in this great event. Allow me to introduce our faculty who are representing the Egyptian Society of Cardiology. We have Professor Gamila Nasser, Professor and past Chairman of the Cardiology Department, Swiss Canal University, and she also the President of the Working Group of Prevention. She is a board member of the Egyptian Society of Cardiology. She has a long, very long CV, so we can take 2 hours to mention everything for Professor Gamila. Professor Yasser Sadeh, a professor of cardiology at Helwan University, and he's one of the experts in intervention cardiology, not only in the Middle East, but also in Europe and everywhere. He's a good interventional cardiologist for many years, especially now for structural heart disease, TAVI, and mitral, everything. And also he's a board member of the Egyptian Society of Cardiology and the past secretary for the Egyptian Society of Cardiology. Professor Hibatullah Ataya, she is one of the experts in the field of adult congenital heart disease, and she is a professor of cardiology at University, Ain Shams University, and she is one of the experts usually involved in different meetings, so we are delighted that Dr. Hiba is joining us today. Going to electrophysiology, a very difficult specialty, but our star of electrophysiology, Professor Ahmad Damati, Professor of Cardiology at Cairo University, and also is one of the experts in the field of electrophysiology. And go to heart failure. Our rising star, Dr. Ahmed Kamal, is a lecturer of cardiology at the Cardiology Department, Cairo University. We have a distinguished group from Africa. Professor Abdul Khan can introduce our guest faculty who are going to present interesting cases, and the session will be an interactive session to present the different specialties in cases from the Egyptian side and from your side, followed by interactive discussion. So be free to ask and to interact with the presenter of different cases. Professor Abdul Khan can introduce your group.
Thank you. Thanks a lot, Magdi. Thanks a lot, dear colleagues, for coming and for sharing with us your, I know, huge and fascinating experience. We are sure that we will learn a lot from you, and thank you so much. We will have the same 4 topics on heart failure, electrophysiology, interventional cardiology, and pediatric cardiology. We'll just start because as suggested by Magdi with the interventional cases, and on the board you are one of 3 of our leaders of in interventional cardiology. From the left you have Professor Mabouri Diaw, who is the head of the Department of Cardiology at Le Dantec Hospital, which is the more historical. It is, you know, when what we call in Latin the alma mater. All of us come from this department, and it is really the department of maybe 1/3 of the colleagues present here. And Prof. Maburi is head of the department, interventional cardiologist. Another rising star, but more than rising star, he's the president of the Burkina Society of Cardiologie, Valentin Yameogo. It is the same. It was trained from Dakar. He's almost my son, I can tell, because I'm becoming old. And Valentin is a brilliant interventional cardiologist. And close to us, another young but very brilliant leader also, which is the head of the Department of Cardiology of what we call Hôpital Principal, that is the military hospital in Dakar, which is very well organized with very well capacities in interventional cardiology, and it is led very hopefully by Professor Sherif Mboub, who will present the case in interventional cardiology. So thank you.
I forgot to mention to my colleagues from the Egyptian Society of Cardiology that Professor Abdul Khan is considered as the godfather of cardiology for all of our colleagues from Africa. So I'd like to thank Professor Abdul Khan for choosing Egypt to host this great event.
I am just a humble friend of Magdi, that's all. This is only my CV. Thank you.
Thank you so much. We can start by... so we can start now by intervention. It's okay. So I'd like to invite my dear friend, Professor Yasser Sadiq, to present his case. Okay, Yasser.
Hello, everyone. It's our pleasure to host you here in Egypt. I have two cases under the title of When the Ibis Lightning the Way. So, first patient, female patient, 52 years old. She has a lot of risk factors: hypertensive, heavy smoker, dyslipidemic, and she's morbid obesity. She complaining of ischemic heart disease with previous trial of BCI to LED 2 years back, but failed and ended by stenting of the LED to the diagonal one. So after that, she complained of exertional angina with minimal effort since 2 years, accelerated over the last 6 months, and admitted in the cardiac care unit with non-STEMI. She was on maximal medical treatment to control her chest pain, but the patient always complaining in spite of maximal medical treatment. Her laboratory finding, as you can see here, nothing except everything is okay. Echocardiography showed normal ejection fraction, and she had dynamic ST segment elevation in anterior leads. So the decision was made for CABG to do Lima for closed LAD, but patient preferred medical treatment and they didn't want to go for surgery after 1 year from the BCI. 3 months later, she admitted again in the cardiac care unit, and we did for her dobutamine stress echo for viability to see if this LAD is viable or not, and showed maximal viability in the territory of the LAD. So significant ischemia with low dose infusion, so we decided to go for now. Okay, as you can appreciate here, there is a stent for the LAD to diagonal, and there is a retrograde filling for the LAD from a tiny epicardial collateral from this right coronary artery. And as you all know that we have hybrid algorithm, we have to assess the difficulty of the CTO and see if this for antigrade or for retrograde or hybrid to go antigrade and then retrograde. And as you all know that we have a GCTO score which assesses the difficulty of the CTO, and the proximal cap is ambiguous, so it takes 1 score, long CTO 1 score, calcification 1 score, and retry before 1 score. So this is G score 4, which is very difficult to get this CTO easy. So I started with retrograde I tried in this epicardial collateral, but it's very tiny, and I can't reach the distal LED, as you can see here. So retrograde with low profile macrocaster and so 3 wire, which is 0.3 gram wire, failed to cross this epicardial. So what is the second option? The second option is to puncture this LED, but it should be IVUS guided because it's ambiguous. So another low profile microcaster, a wire in the diagonal in the stent, and then to see by the IVUS where is the entry of this LED. So as you can appreciate here, the IVUS showing the stent of the diagonal, and then at from 3 to 5 o'clock the LED comes, so you can puncture during the live IVUS toward this, as you can see here in the second picture, at 6 o'clock, you can puncture by Conquest to Bro 12, which is 12 gram, guided by IVUS at the same time. And after we sure that we are in the architecture of the vessel, we did de-escalation with Gaia 2nd, and finally Gaia 3rd reached the LED in the true lumen, which is very important for this lady. And after that, pre-dilatation and stenting of this LED by one stent, 3 by 38. And as I told you before, this CTO more than 5 years. So remodeling of the vessel should be respected. We did IVUS for the distal LED and we find everything is okay. So we did recrossing, casing for the stent of the diagonal and the LED. And after that, final bot for the proximal stent of the LED. And then this is the final result for this lady. And as you can see here, so the patient improved dramatically and her chest pain controlled, discharged from hospital next day with no complication. Case number 2, this is male patient, 95 years old, diabetic, ex-smoker, ischemic heart disease. He has a CTO of LED, another ambiguous stump. As you can appreciate here, there is a side branch and we don't know exactly where the stump of this LED. But this is a long CTO segment and failing retrograde from the right coronary artery, as you can appreciate here, with good collateral for this LED. We tried antegradely, but actually we can't reach the true lumen of the LED. As you can see here, this wire is outside the architecture of the vessel. So we shifted to, this is what mean by hybrid algorithm. We shifted for retrograde and finally by this caravel macrocaster and so 3 wire, as you can appreciate here, because this is very tiny collateral. You can see here now, and then to the LED, as you can see, it's very tiny collateral. So this is finally my wire in the LED, but the problem is not here. The problem is here. Actually, the stump distally is ambiguous too, and I can reach the true lumen of this LED. And at this point, this is very critical maneuver that if you go with puncturing wire to puncture in the proximal LED, you can do a dissection in the LED and extending to the left main. So be careful for that. So how to do different views and see what is the direction of the LED. So the IVUS helped us a lot. We did wire in the circumflex, and this is again IVUS in the left main to see where is my wire. And you can see here my wire at 9 o'clock in the subintermal space hitting the true lumen. So during live IVUS, I punctured towards the true lumen, and now my wire in the true lumen at 6 o'clock. You can see here the wire in the true lumen. So this is very important to avoid any dissection in the left main. Then we did recross to the anti-grade guiding, and then G3 long wire in the LED to the anti-grade RG3 wire, then pre-dilatation and IVAS guided BCI for this LED, this 2 stent in the LED, 3.5 by 38 and 4 by 23, and then post-dilatation and IVAS post-stenting to see the stent, it's okay, and after that post-dilatation after IVAS, both in the left main, and this is the final result. As you can see here, it's long LED and it's remolded, and it increases with time after medical treatment, and this is the final result. So my take-home message for both of the two cases: be ready for all solutions you have and follow the hybrid algorithm. Don't stuck in the failure mode. We have to respect the anatomy of the LED. If you failed antegrade, you have to go retrograde. If you failed retrograde, you have to use another tool like IVAS, as I did. IVAS guided to puncture the ambiguous stump is very helpful tool. Thank you.
Thank you very much. I don't know if there is a comment or question. Bien sûr, s'il y a des questions, vous pouvez les poser en français. Je ne sais pas si Mabouri ou Sherif ont des commentaires à faire. Is there any comment in the room about these fantastic two cases? I think that the term plasty makes sense when we are following you, because you really repair this artery.
Okay.
Je pense que vous avez bien suivi. Hein. L'idée globale, c'est que les occlusions chroniques sont un défi et que pour y arriver, il y a plusieurs voies, antérograde et rétrograde, hein, comme disent les gars. Je parle de choses que je ne connais pas tant que ça. Et les deux cas nous montrent l'importance de l'échographie endocoronaire, puisque je crois que les coronarographistes acceptent bien le principe que la coronarographie n'est qu'une luminographie et que vaut mieux voir où on est. Et en l'occurrence, dans les deux cas, il a pu, sur le premier, voir la voie la plus appropriée. Dans le second cas, il ne savait pas trop s'il était réellement dans l'artère interventriculaire antérieure, et c'est grâce notamment à l'échographie endocoronaire qu'il a pu identifier la vraie lumière de l'artère et pouvoir secondairement dilater et mettre le stent. Et vous avez vu la belle reconstruction de cette artère qui était occluse de façon chronique et sur une très très longue distance. Sherif.
Thank you very much, Professor Khan, and congratulations to our colleague. It was very wonderful cases, two cases. And just to share with you your experience about CTO and about anterograde technique. And when you are doing wire escalation, as you tell to us, what is your first wire that you use in daily practice? Do you prefer soft wire or maybe Gaia 2, Gaia 3, or do you start every cases when you are doing wire escalation with Fielder XT or other guys?
This is a very good question for all who want to do CTOs. For anti-grade escalation wire technique, there is two schools. One for the beginners. The beginner should follow the rules. So go with the microcaster, with workhorse wire, then escalating to hydrophilic wire, one of the Fielder family. Then we can escalate for more puncture wire like Gaia, Gaia second, Gaia third, then Conquest to Bro 12. And if the CTO is, the operator is well trained, he can do some shortcut. Like if he has a clear proximal cap, you can go with the microcaster over workhorse wire and then go directly to the Gaia family and escape the Fielder. But we have to follow the rules of escalation, as you mentioned. Escalation wire technique for all who in the training should go with workhorse wire, one of the Fielder family, then Gaia, then Conquest Bro 12.
I have a big comment. I really feel very happy to be in this African gathering, and really Many thanks, endless thanks are due to Professor Magdi Abdelhamid for this and all the African who are, making a festival of cardiology in Egypt. Thank you very much, and a big welcome to Egypt. Professor Yasser, I'm just asking, what about the role of viability? There is ups and downs in myocardial viability in this patient. Do you think that you said that the whole myocardium was viable, and we do have a lot of ways. What do you think the role will be of detecting myocardial viability in such patients?
Yeah, actually, when we have left ventricular ejection fraction depressed, and the patient didn't complain of chest pain, just ischemia and depressed LV function, we have to assess the viability. Why? CTO is expensive procedure, and we have to get a benefit for all those patients. So all my patients with depressed LV function, I should send them to do viability by echo or by MRI or by Salium. So when there is a viability, we go, and this is very crucial. With all patients with normal ejection fraction and complaining of chest pain and has CTO segment, I prefer to go directly to open this CTO without any viability, because the patient has normal ejection fraction and no need for viability. This is my practice.
Okay, thank you very much for the two excellent cases. I'd like to know, I know that we can use IVUS, but it is possible to use OCT too. And why have you decided to use IVUS instead of OCT?
Yeah, IVUS in CTO, it's applicable in to get a puncture, but OCT is very difficult. Why? It needs more saline, and it's not compatible with 7 French guiding caster and microcaster, because the caster of OCT is more bulky, so it needs 8 French guiding caster. So in both two cases, it's only 7 French. So this is first. Second, to see the ostium of the LAD and the ambiguous thumb, it's more clear with IVUS. But to see the stress of the stent and to size and to see the structure of the vessel, it's better with OCT. Actually, for reimbursement issues, we prefer to do IVUS here in Egypt, and the cost OCT here in Egypt is like 5 times the price of IVUS. So the IVUS is okay, applicable in every hospital, but OCT in a special hospital with very high cost. This is very important.
Thank you, Dr. Yasser. Just for the two cases, I want to know if you oftenly use IVUS for CTO or sometimes just rarely to use the IVUS.
For regular BCI, you mean?
For CTO. Or you oftenly use IVUS for doing CTO or not? In terms of time, you spend a lot of time to use IVUS for the CTO, or is the same maybe?
It's a complementary in most of the cases to know where is to size and to see the remodeling vessel and to minimize the number of the stent. It's very important. But actually, in all honesty, it's a complementary method. But in these two cases, it's a must. I can't reach the LAD in the first case with this stent without guidance of IVUS. The second case, I can compromise the left main and the LCX without this IVUS. So this is, I choose these two special different scenarios when the IVUS is mandatory. But the percentage of my practice to use IVUS in CTO, not less than 10 to 15%.
In terms of time?
10 to 15%.
No, of time. You spend more time doing when you use.
No, it's okay. It's the same time. You work with microcaster wires. So CTO, it's costly and long procedure. So it's not more than 5 minutes. It's okay. Thank you. Thank you so much.
Thank you so much, Professor Yasser, for this excellent case. Now we will move to the next speaker. Professor Abdul Khan, can you introduce the next speaker?
Thank you. It's the Professor Sherif Boop is an interventional cardiologist, and he's the head of the department of cardiology of Hôpital Principal of Dakar, which is one of the main hospitals in Senegal. Prof. Boop have, I think, an interesting cases of coronary heart disease. Si on peut avoir une petite chaise à côté, ce serait bien. Non, non, pas le chef quand même. Bon. Quiconque osera s'asseoir sur cette chaise. I wanted a chair, and it is the boss who is bringing the chair. I'm not sure that someone will be able to sit in this chair, brought by the big boss himself. Ça va, chers collègues, je vous sens très concentré sur la cardiologie interventionnelle et sur les méandres des occlusions chroniques, et qui nous montrent que il vaut mieux voir son chemin. C'est vrai que les cardiologues interventionnels ont l'habitude de marcher dans l'obscurité, mais si vous avez des yeux tels que l'écho endocoronaire, c'est encore mieux. C'est ce que nous a brillamment démontré notre collègue. Prof Mboup, dès que tu es prêt, j'arrête de faire diversion, donc je continue de faire diversion. Okay, it's ready. So, Prof Mboup.
Okay, thank you very much, Professor Khan, and I want again to thank a lot AJANTA and the Egyptian Society of Cardiology to be here in this very good country and to share with us our experience. I cannot say in interventional cardiology, but in cardiology, because I choose these cases because it's a transversal cases moving from rhythmology to interventional cardiology and to imaging. The title is Finding the Substrate. It is the case of a very young patient, 26-year-old patient, without any risk factor and without any severe disease. And this patient, the day before the hospitalization, he was symptomatic with brief palpitation, with abrupt onset and termination, associated with shortness of breath. And the day of the hospitalization, the palpitation was more longer, and the patient have atypical moderate intensity chest pain. Given this symptom, he go to the level 2 healthcare facility, another hospital. And when he arrived in this hospital, we do this EKG, and as you see, it is a tachycardia with wide QRS, and maybe we can conclude that probably it is a ventricular tachycardia. When we see in AVR, we see that the R are very wide, and it's compatible when we see with Verrecke algorithm. It is ventricular tachycardia. Donc, given this fact, in this hospital, they give to the patient a loading amiodarone with 1080 milligram oral amiodarone, and decide to send the patient to our department. When the patient arrived in our department, he was free of symptom. The physical examination was quite normal, and blood pressure, less tachycardia, and the saturation of oxygenation was normal. When he arrived, we do again an EKG, and as you see here, is quite normal. The patient is in sinus rhythm, despite one extrasystole, and when you look at the extrasystole, it looks like the same QRS when the patient was in tachycardia, and we maybe can conclude that probably it is a ventricular tachycardia. And when you receive a patient with ventricular tachycardia, it is normal to know if the patient have cardiac disease and what kind of cardiac disease. Donc, first of all, you do blood test, and the blood test show that troponin and D-dimer was normal, only the CRP was elevated, and others blood test was quite normal. And as I say previously, donc we do echocardiography, and I will show you the image. And the echocardiography shows us normal size of cardiac chamber in hypokinesia in one segment, inferolateral basal segment with aneurysm. And in this segment, we saw an hyperechogenic image. The other segment was normal, the LAF was quite normal, and the global longitudinal strain was not good. And okay, and if you see here in the two vessel chamber, there are no problem, but in the three vessel chamber, if you see in the inferolateral basal segment, we have hypokinesia, and we have an hyperechogenic image that we don't know what it is. If it is mass, a tumor, if it is thrombus, what it is. We don't know, but we are sure that in this segment is not normal. And we do again strain at the end of the exam. And what do you see in the strain? We have positive value in the inferior segment, inferior and inferolateral segment, and the global strain was abnormal, less than 20%, and the ejection fraction was quite normal. Donc the strain, as the other images show that in this basal segment there is something abnormal. And to advance in our diagnostic strategy to find the substrate, what do we have in this segment? We send the patient to cardiac MRI, because as you know, cardiac MRI give us tissue characterization, and it is more valuable than only echocardiography. And cardiac MRI, I will show you the cardiac MRI. What do we see? That in one segment, we have again an abnormal thing. Here it is SSFP 2T2 weighted imaging, and as you see that it is normal kinetic despite this segment. This is hypokinetic, and again we have an hypo signal in this segment, but we don't know again what it is truly. And when do you see it in your right, the other sequence, it is a late gadolinium enhancement sequence, and you can see two things. First of all, in red, that we have an LAG, transmural LAG in this segment, and we can conclude that it is myocardial infarction because it is transmural. And second, we can conclude that this mass that we have seen in echocardiography, hyperechogenic imaging, it is a thrombus. And this patient have myocardial infarction complicated with thrombus localization in only one segment. And why this patient without this factor can do myocardial infarction in one segment and complicated with thrombus? Finding the substrate. And we move again to another imaging, maybe coronary angiography is imaging. And what do we see? Maybe it's very fast, the imaging, but if you take time to look, the right coronary artery is normal, the left coronary artery, the LAD was quite normal, but when you look at in the circumflex, the first marginal is normal, the second marginal is normal, When you look in the distal circumflex, you see that sometimes you see your circumflex, but another time you don't see your artery. And maybe if I stop the image, and you can look that during the diastole, you see the distal circumflex, but during systole, the distal circumflex disappear, and this confirms that our very young patient have what we can call myocardial bridging complicated by or revealed by myocardial infarction complicated by ventricular tachycardia and thrombus. This is the substrate of the substrate of the substrate. And given this conclusion, we give to the patient beta blocker, bisoprolol, and anticoagulation, apixaban, and we see the patient 3 months later, and as you see here in the 3-vessel chamber, that the thrombus disappeared, but in this segment, we have an aneurysm of, in this segment, and the 2-vessel chamber, as you see, is quite normal. And at this time, our question is, did we stop or not apixaban? Maybe you will give me the answer. I don't know. And we can maybe conclude with this picture, what is myocardial bridging. You know, normally the epicardial coronary artery course, it is between the pericardium and the epicardium. And sometimes in congenital anomaly, this is a segment of our artery is inside the myocardium. If it is superficial, less than 2 millimeters inside the myocardium, it is typically asymptomatic. And when the course inside the myocardium is deeper or longer, as you see here, it can be potentially symptomatic, and in some cases can lead to myocardial infarction. And thank you very much for your attention.
Thank you, Sherif, for this very nice and rare presentation. I don't know if the panel of specialists, you have a...
Dr. Sherif, a very nice presentation of a full case and very interesting actually. The point is, it is very rare to have a limited aneurysm in this area of the myocardium, as you said. And the point is, it does not actually correlate with the area that is embedded from the circumflex. It's rather more basal, in the basal segment. You said that the right coronary is dominant, and it's not dominant?
No, it's not dominant.
Okay,
it is normal, but it's not
but
dominant.
the area supplied with this impeded circumflex is rather more apical. I don't know, I'm not sure. Do you agree with me or not?
No. The apical, as you see, is supplied by LAD. It is a left dominant coronary artery, and the basal segment, as you say, if it is left dominant coronary artery, it's supplied by the cell. Now they are correlated with anatomy and echocardiography.
Okay.
Y a-t-il des questions dans la salle, le temps que Prof Mabouri?
Thank you, Sherif, for this nice case. I just want to know, how do you explain the elevation of the CRP, C-reactive protein? Maybe I think it was 108. And I don't know if in this audience someone can explain me if you can sometimes have an association between myocardial infarction and myocarditis, is it possible or not? I never see this case of association between the two diagnosed. I don't know if is it possible or not. That's why I ask you this question.
An explanation, Sharif?
We don't say that it is an association between myocarditis and myocardial infarction. For us, it is a myocardial infarction, not at the acute phases because troponin was quite normal, but for us, the elevation of the CRP, it's look like probably due to myocardial infarction. As you know that if we have myocardial infarction, we have an inflammation, and for us, it is why the CRP are elevated. It is that, but it's not association between myocarditis or a myocardial infarction. For us, it is a myocardial infarction due to myocardial bulging. It is rare, but it's previously described when you see in the literature.
I do agree with you. I think that it's clearly the MRI, even the echo in subancardial phase, you see that it's a myocardial infarction. And I just want to remember, if you have a large thrombus like this, have another inflammatory process, I think that it can explain a high CRP in this case. Yes, in the audience, two or three, a microphone, and then here, Adama, Leopold, Adama. The boss is working a lot. I don't like the boss is.
Okay. Thank you.
It just tell you how should be a leader. The leaders have to be like this. Leopold.
Thank you for these wonderful cases. I have one question. What is the real treatment of this myocardial bridging? Because you give antiplatelet, you give anticoagulant for the thrombus, but what is the outcome? And if there is no treatment, I think that we have to continue this anticoagulant because the synetic will not recover, and we can have the recurrence of this thrombosis. Thank you.
Sharif?
The treatment of the myocardial bulging, typically in most of cases, it is an asymptomatic situation, but even if it is a symptomatic situation, the treatment is maybe for a lot of time medical treatment without stenting or other thing, medical treatment with beta blocker or with calcium channel inhibitor. We avoid to use vasodilator, but beta blocker or inhibitor calcium, it is sufficient in a lot of time. About anticoagulation, we discuss because after 3 months the thrombus disappear. Some of my colleagues is for anticoagulation, but me, I'm not very sure that it will be good.
So, please. Yes. Okay, thank you, Sharif, for this very nice case, but the beginning of the problem is an arrhythmia problem. So I don't know what you deal with this arrhythmia problem. I think you have the substrate is clear, so I think if the medical treatment is not correct, we will propose an ablation of this arrhythmia because you know the substrate.
Yes.
I think it is something you have to add to your presentation. Thank you very much.
What I can see that we have done only one episode of ventricular tachycardia, and during this time, in 3 months follow-up with bisoprolol, we cannot, we don't have any recidive of ventricular tachycardia, and the ventricular ejection fraction was quite normal, and I think with bisoprolol it will be enough. And maybe if of recurrence, we'll send you the patient.
Okay, thank you very much, Sharif. I have one question. What about mitral valve?
What about?
Mitral valve. Was it competent? No insufficiency? Because the location is at the level of small valve. And in the literature, I have seen some cases called illegitimate mitral valve insufficiency, and sometimes it's very dramatic.
Yeah, hopefully for this patient, he don't have any mitral insufficiency, and it was quite normal.
Normal.
No, normal. No problem.
Okay.
Please, how do
Maybe
you...
one final question
Yes,
with the
yes.
doctor. Have a lot of bosses trying. Okay, short
Well,
with Anise and then Babakar, and then we will close.
Okay, thank you. How do you explain the late manifestation of bridging myocardium?
What is?
How do you explain the late manifestation of the myocardial bridge?
We don't have maybe any explanation why it is become late, but the patients are not very old, 26 years, as you see. We don't have any explanation.
Can I try an explanation?
Maybe, Professor.
Can I try an explanation? I just wanted to remember you that the milking is in systole, of course.
Yes.
The bridging is in systole. And I remember you that if the coronaries are filling in diastole, which is representing more than 2/3 of the time. C'est 2 tiers ou plus. Enfin, on se remplit en diastole. Et donc la question simple, c'est pourquoi un pont myocardique, why a myocardial bridging can cause ischemia? Because it's mainly in systole. And the coronaries are filling in diastole. I think one explanation is that if you have a strong, it is the mechanical thing, a strong milking, un pont avec une compression systolique, en fait, ça va se relaxer lentement en diastole. Donc le remplissage diastolique est gêné. So a long milking can induce a diastolic decrease of the filling. One explanation. But I think that we have other mechanism in myocardial bridging. It is atherosclerosis. Yes. You have to remember that. That's why I think that it could be interesting to have an IVUS or one coronary bridging. What is known is that because of the stress of the vascular wall, before, en amont du bridging, en fait, on a souvent le développement d'une dysfonction endothéliale, d'une plaque d'athérome et donc d'une thrombose. And that's why your question can be interesting. We have to pay attention to atherosclerosis in such a patient because we have one of the mechanisms is atherosclerosis and a thrombus, not in the bridging, but before the bridging because of the shear stress. I think that it can be a mechanism. And as said, it can start at, usually it is an adult or something like that. It's not so earlier. But I think that we have to remember that the mechanism can be the bridging itself, but usually it is asymptomatic. But one of the main mechanisms is endothelial dysfunction and atherosclerosis because of the stress induced by the myocardial bridging.
And we can add vasospasm again.
And vasospasm, thrombus, and atherosclerosis. Exactly.
It is the three mechanism.
Yes, that's why the question can be, because you asked it, what is the next step? I think that it could be interesting to check for the arteries if it's possible.
A very amazing discussion, and should we shift to the next speaker for the sake of time?
Yes, thank you so much.
Thank you so much. Just an amazing presentation, and I really have the honor to introduce the next speaker. A very elegant Egyptian cardiologist, and we're always proud of her. And she's had a lot of research work in the field of congenital heart disease, and she is the professor of cardiology Ain Shams Distinguished School of Medicine in Egypt, as well as she is the vice president of the working group of women and heart in the Egyptian Society of Cardiology. I do have the honor to introduce the very elegant professor of cardiology, Dr. Heba Atiyah, and she's going to give us a presentation about coarctation in a small aorta.
Good morning, bonjour. I'm delighted to be among you. Thank you, Dr. Gamira, for the introduction. Thank you, Dr. Magdi Bey, for the invitation, for the kind invitation to take part of this. I'm really proud to be speaking among our brothers from different countries in the great continent of Africa. And thank you for the organizing company from India to to allow us to take part in this. This is a really good time for the South to rise, and I'm really happy to be part of this. I decided to speak I'm specialized in pediatric and adult congenital heart disease, and I have chosen to speak about something that we usually or sometimes might face. I usually face, other cardiologists sometimes face, which is the coarctation of aorta. I have no financial disclosures. Our case is a male child, AK. He was born on March 2012, and the first presentation was intracranial hemorrhage on May 2019. During the clinical examination, he was hypertensive with discrepancy in peripheral pulsations. His blood pressure was 150/90, and he became controlled on captopril, 12.5 milligrams twice, with a blood pressure of 110/80, which is the 90th percentile for his age. In the workup of investigations, the echo revealed severe coarctation of aorta with a maximum pressure drop of 90 millimeters mercury with a diastolic tail, and also the pulmonary arteries were small in size with a mild origin stenosis of the pulmonary arteries. His systolic right ventricular pressure was 30 millimeters mercury, which is mild, shows a mild obstruction. As part of his workup, we did a multi-slice carotid and cerebral angiography, and it showed total occlusion of the subarachnoid segment of the right internal carotid artery with a distal runoff at the anterior and middle cerebral arteries. There was also total occlusion of the distal aspect of the subarachnoid, of the supraclinoid segment of the left internal carotid artery, and there are focal pouches in the carotid. And with reference to this multi-slice CT of the carotid arteries, it raised the suspicion of a certain disease. Anyone has something in mind or faced a similar CT angiography? Well, it is rather a rare finding. It is a moya-moya disease. This disease is more present in Japan and in the South Pacific. And it is a disease with progressive cerebrovascular disorder that causes blocking of the arteries at the base of the brain in an area called the basal ganglion. The meaning of moya moya is a puff of smoke in Japanese, as we see here that this shows in the pointer. This shows the pointer is not working. Oh, sorry. Pointer is not working. Well, actually, as we see here, that there is this puff smoke. It shows like at the end of the artery, it shows like a smoke, and this is the moya moya, very characteristic clinical picture, although it looks really rare. And the tangled appearance of the blood vessels in the second panel, as you see, there is a tangled appearance. The blood vessels, the small blood vessels, appears to be tangled with each other, and in the filling, it shows the puff of smoke. There is not a lot of publications about the moya moya, and in the Western, there is only a single large registry in the Western moya moya disease population, which is out of Japan. And it has a descriptive study. It was done in the records of 19, they collected the data over 29 years, and they collected only 181 moya moya disease patients, and the prevalence of congenital heart disease in this population is larger than or higher than the normal population, but it's still not that high. In our patient, when we did the CT, it showed severe coarctation of aorta, which is near interruption, and it showed that the peripheral pulmonary stenosis is rather insignificant. So the plan was to dilate this aorta. Usually when we do an intervention for the carotid artery, we do a femoral puncture, usual Seldinger technique, if we have continuity from above to down, and even if it is interrupted, we start angiography with the femoral puncture, but we do angiography in the abdominal aorta to compare the sizes of the femoral arteries in order to choose the larger size to get our access through, because usually there is discrepancy between the two femoral arteries in size. And this showed this injection, the second injection was done in the aortic isthmus. It shows a near interruption, but as we can appreciate here, that there is some turbulence of flow facing the dye, and through this we entered with an end-hole catheter, a PTCA wire, to gain access to the aorta, and it was not that difficult actually. We gained access and we parked the PTCA wire. It was a usual BMW wire that was in the cath lab. We parked it in the left ventricle to gain the access, and then we did a selective angio in the aortic arch. Sorry. We did an angio. Sorry, it's not working. The second angio is not working. We did balloon dilatation because the child was too small to do stenting for his aorta. The diameter of the aorta was 8 millimeters. We dilated with an 8 millimeters tie shack low profile balloon, and then 8 millimeter Z-Med high pressure balloon. 6 months later, with a drop of pressure gradient was 10 millimeters mercury, the spontaneous gradient. 6 months later, the child came with recurrence of symptoms, so we decided to gain access by a vascular surgeon in order to avoid harming the small femoral artery that had a diameter of 3 millimeters while introducing the sheath. And we decided to stent due to recurrence of symptoms. We've chosen to use a biliary stent that is a balloon-mounted stent, and it has a low profile, and we can introduce it through a 7 French sheath, which is the largest sheath diameter his peripheral arterial disease can accept. This is how we stented the coarctation, as you see, and as we see that it recoiled back. Actually, the Valeo stent we used, which is a biliary stent, the company stopped making. They don't produce anymore. And this we did with, this is a bare metal stent. This shows an injection, and we could not dilate more to avoid rupture of aorta. The pressure gradient dropped and the functions improved. The patient came for follow-up after 1 year, and in the follow-up there was a rising gradient, so we decided to dilate the stent again using a high pressure balloon, which was Dr. Ozipka 12 millimeters 4 centimeters balloon. But we could not ablate the waist because this has a very high risk of rupturing the aorta. Follow-up after 1 year showed recurrence of gradient, but with no actual turbulence through the echo. So we did an angio in a trial to evaluate the periphery, as we said that the dilatation of the aorta usually in patients with coarctation leads to improvement of the size of the peripheral arterial tree and the femoral arteries, and the arteries actually did not increase in size much, and it could only accommodate a 7 French sheath that we introduced through, and we did an angiography that show what we say a napkin paper stent with a distorted anatomy, as you see here. We suspected, and as we see, the network of collaterals has declined markedly after this dilatation. We did a stent boost that is used in the coronary stents just to see that the stent is broken, so we could not go and dilate it again, and this was the gradient. So we have now a problem. We have a broken stent, and the broken stent in a coarctation means that we have to get a covered stent inside it to avoid rupture of the aorta. We have a small diameter of the descending aorta, which is 12 millimeters, and we have a femoral artery that is 4 millimeters that cannot accommodate more than 7 French sheath. And also we have the cerebral problem that we have. This is from the endovascular today. This is the manual for the stents present in the market that we can use, the covered stent. As you see that once we jump from the size 10 to size, the smallest diameter of a stent that can we use is 12 millimeters to be dilated to more than 14 millimeters, and all of them, they need a larger sheath. After consultation with the vascular surgeon, we referred to the literature, and as we found that the mechanical properties of low diameter balloon expandable covered stent, we could not go to less than 14 millimeters, which is less than the larger than the diameter of the descending aorta. So our plan was just to follow up the patient until we treat the carotid arteries or until his aorta is larger, and do surgical intervention with major repair of the aorta. Thank you very much.
Thank you so much, Professor Heb. Excellent case for a very rare, challenging case, difficult to diagnose, but well managed.
My point in this, that you should stop when you have to stop. Yeah. We cannot go further, actually. You should stop, you should know when to stop. Actually, this case I've sent to my Professor Mario Carmanati and Shakil Qureshi and Ziad Higazi, and they told me, stop, we cannot do more. And the treatment will be surgical if possible, if we need more.
Any question from the floor regarding this case? Yes, please.
I think we can maybe switch our pediatric specialist, Professor Lei. I think you can.
Please join us, please.
Your place is here. It's René Baragou and.
Yes. Thank you. Thank you so much.
Because it's almost an interventional case, I will think, but.
Thank you very much.
Well, the pediatrics. René, please join us. And then the third moderator.
Thank you very much for this very nice and interesting case. My question is, why don't we do surgery for this patient at the beginning? Because we know that the problem in young patients is to have good vascular access to do stenting, and if we put stents when the patient grow, you have discrepancy between the final diameter of the stent and the final
Shorten.
diameter of the aorta? Yes.
Thank you for the question. It's a very good question. Actually, this patient should have been treated surgically, but the surgeons, due to the cerebral affection, and you know, of course, that with the aortic surgeries, that there is, with the reverse flow during when he's on the machine, usually they fear of any cerebral complications, and he had at that time some weakness with his blood pressure shooting and increasing more or less. So the surgeons asked us and the neurologists to control his aorta partially, and then they might go to do the surgery.
Professor Heba, it's an excellent case, very tough. So I want to ask you about the choice of the stent. When you choose in such young age graft stent versus bare metal stent, there has been any preference other than the vascular access and the size of the sheath?
Yes, there's a preference, of course, if you have the branching vessels, if you are entangled with the neck vessels, so you use the bare metal stent. Actually, in the last decade, people were more comfortable using covered stents because it has less complications with dissection of the aorta. But we used the CP stents 25 years ago, and we were comfortable with it. If you place it properly and if you dilate it properly, you will have good results. The choice of the covered or bare metal stent, it goes also with the position of the coarctation, if it is in the isthmus, descending, entangling one of the neck vessels or not, and the vascular, also the vascular complications, the size of the sheath. Unfortunately, with small aortas, we don't have a choice. If you have an aorta for 12 millimeters, you should use bare metal stent and you should use biliary stents because they cannot go to the small sizes. The covered starts from 12 to 14.
So now we can invite the next speaker.
The next speaker? Okay,
Thank you.
Thank you so much for this fantastic case. And so we move from Cairo to Cotonou and invite Prof. Leopold Kojo to present the case, the second case of pediatric cardiology. And we will be honored to have Prof. Diarra, one of the pioneers of pediatric cardiology, to join us, please. Prof. Diarra.
Okay. Thank you. I will try to speak English. So, my case is about infective endocarditis of a tricuspid valve caused by Staphylococcus aureus after any arthritis in a 3-year-old boy. So, he's 3 years old and he has no medical nor surgical history. He was admitted for exploration of fever. So this started 3 weeks before, and he complained for fever, polyarthralgia. There was no chest pain, no dyspnea, no cough, no syncope. Few days later, despite different medication, there is a recurrence of fever, and it was associated with limping on walking, non-traumatic swelling, and right knee pain. There were also polypnea and productive cough. It brings out yellow expectoration. For that reason, he was admitted to pediatric ward of the National University Hospital of Cotonou. At the admission, his general condition was bad. There were fever, tachycardia, polypnea. His oxygen saturation was normal on room oil. His BP was normal. He weighed 15 kilograms, and he was tall for 1 meter. the right knee was swollen and tenderness and warmth. There is at a respiratory pulmonary examination, we have abolition of vesicular murmur, dullness, and at the lower half of his left lung. So head sound were regular but fast, and there were a tricuspid murmur and right head failure signs. So there were no there were no finding of Osler's nodes, Janeway lesion, or finger hemorrhage. No other abnormalities at this examination. So, in summary, we have a 3-year-old boy who has, since 3 weeks, systemic inflammatory syndrome, left knee arthritis, tricuspid murmur, and left pleural fluid effusion syndrome. Also, right heart failure syndrome. So for this case, the arthritis is evident, yes. But we hypothesize that he has a complicated right-sided endocarditis. For this, we perform a chest X-ray, which reveals left pleural effusion, and also at transthoracic ecography, we have a large vegetation on the tricuspid valve and also enlargement of right side cavities. There were also middle tricuspid regurgitation. So left heart was normal, and we can see inside the pulmonary artery, it was not possible to show the left and the right artery, and in the right artery, we can imagine that there are some ecogene structure inside. In blood tests, there were inflammatory anemia, neutrophil hyperleukocytosis, and low platelet. At the function of the left knee, we have purulent synovial fluid, and the culture of this fluid reveals Staphylococcus aureus. Also, 3 blood culture reveal also the same germ. Gene aspect of knee fluid was negative, and there was no more other abnormalities. So for this case, we saw 2 major criteria of endocarditis, particularly vegetation and positive blood culture for Staphylococcus. Also 2 minor criteria, fever and pulmonary embolism. So the diagnosis was definite infective endocarditis of tricuspid valve caused by Staphylococcus aureus after knee arthritis. And it was complicated by septic embolism, pulmonary embolism, and severe thrombocythemia. So the treatment was immobilization with plaster cast on the left knee, antibiotics. This antibiotics was probably at the beginning, and we adapted it with with antibiogram. So we use ofloxacin, vancomycin, and because the fever was not improved, we add cotrimazole. He had also blood transfusion of red cells. So with this treatment, the fever decreased by week 3, and we have the regression of inflammatory knee swelling. Inflammatory biomarker also improved, but this boy experienced worsening of the cough and the dyspnea, and there was increased signs of right heart failure. We hypothesize that is the recurrence of pulmonary embolism. At TTE, we see the reduction of the size of the vegetation, and the tricuspid regurgitation becomes severe. So this was compatible with pulmonary septic embolism recurrence. So we introduced furosemide and we continue antibiotics. After multidisciplinary staff, we decide for the surgery. So this surgery was performed a few weeks later at Bordeaux, and the right catheterism before this surgery showed septic and thrombotic occlusion of left pulmonary artery. The surgery was a tricuspid valve replacement by bioprosthesis and plasty of left pulmonary artery. The control few weeks later show few thrombotic element inside the right pulmonary artery and the correct functioning of the tricuspid valve. They decided to conduct warfarin for 3 months. That will switch by aspirin. And a few months later, after when he come back to Benin, the TTA control show normal size of right cavity and the well functioning of the tricuspid valve. The pulmonary artery was free of thrombosis. So this case of right side endocarditis is usually favored by many conditions like a congenital heart disease, a drug use, immunodepression, intravascular catheter. So in our case, the knee arthritis is an unusual condition, and these unusual conditions are reported by other authors. We can see breast scan abscess, psoas abscess, knee arthritis, and abortion. And the principal microorganism was Staphylococcus. And this Staphylococcus can be responsible in 60 to 90% of right side endocarditis. We can see also streptococcus, fungi, and Pseudomonas aeruginosa. About the treatment, surgery is recommended in complicated endocarditis. And for the right side endocarditis, when we have right ventricular dysfunction, secondary to severe tricuspid regurgitation, when we have large residual vegetation more than 20 millimeters after septic embolism, when we have persistence of vegetation and insufficient respiratory. So this condition were the condition of our boy, because we have septic embolism recurrence, we have important tricuspid regurgitation. So when the surgery is recommended and not performed, the prognosis was is very bad. And in this case, this cohort of Euroendo, they show that at 30 days, the mortality is around 30%. So it's important to perform this surgery. The remaining questions are what will be the duration of this aspirin, and what will be the outcome of this thrombosis? Is it need to do regular control with a pulmonary scan? That the question we can discuss, and I want to bring out 2 messages from this case. The first message is when we have a long-lasting fever, it's important to look for endocarditis. And the second message is when this endocarditis is complicated, it's important to discuss surgery. Thank you.
Thank you so much. Very interesting case. Congratulations. Proper diagnosis, proper management. I have a short question regarding the value of right side heart cath in the presence of septic recurrent pulmonary emboli. Is it indicated before sending the patients for surgery, or what do you think?
You talk about the right side
cath that was performed before surgery.
Faut-il faire un cathé dans un environnement septique comme ça?
I don't know if they did it at Bordeaux, but I think it was to check what is the status of the pulmonary artery, because at echography it was not possible to study it properly.
Very nice presentation, but do you think that you agree with me there is a changing pattern of infective endocarditis in all over the African continent, as we can see? We've witnessed young infants, young children having increased congenital heart disease. We have decrease in the incidence of rheumatic heart disease. This is, I want your comment. The second, what about the infant endocarditis? And usually we have witnessed the infants who just have been born and you just discover that they had infective endocarditis post-mortem. Do you think, how frequent you find these infants?
Je pense que j'ai besoin d'une petite traduction.
L'endocardite néonatale, alors donc deux niveaux. Il trouve que régression de la cardiopathie rhumatismale et donc nouveau visage épidémiologique des endocardites, et puis le cas particulier des endocardites néonatales, dont il constate une fréquence accrue. Des cardiopédiatres.
Bon, je pense que c'est une contribution, oui.
Professor Lee.
Thank you so much. Very interesting case. Effectively, right side endocarditis, we often see it after abortion or in using drugs persons. But in pediatric patients, sometimes we can have it when we have a PDA. After an infection of a PDA, we can have retrograde migration of vegetation, and if you have a small tricuspid regurgitation, you will have an tricuspid infective endocarditis, and in the same case you can have embolization in the left pulmonary artery when there is a PDA. The second situation is when you have a VSD, a small VSD, shunting from left ventricle to right ventricle. It creates a jet lesion, and in this jet lesion secondary you can have an infective endocarditis. It is a situation where we have seen in our experience infective endocarditis in pediatric.
Okay. Just to add, we have some cases of immunodepression, and with sickle cell disease, I see some cases with children who have sickle cell disease, drepanocytosis.
Thank you. Thank you so much. I think that we will need a 1 week case report with both our societies. Thank you so much, Leopold. And then we are moving to the electrophysiology, and we will replace the expert by the arrhythmia group. So Anisse Babakar, please join us, and Adama will have his presentation of a young lady with a cardiac conduction problem. Post-cafe, yes. No, the post-cafe is a free post-cafe sitting, so you can take your coffee and come back. We will moving, because one of the important thing is that the Nile, we have to be present before it is in between ducks, because the Nile is one of the best river of the world, and you have to not to miss it.
Okay, we can move to the electrical part of this session.
Thank you very much. We thank AJANTA to permit us to deal with some scientific problems, arrhythmia problems, with our colleagues from Egyptian Society of Cardiology. So I present you a case of a young lady with cardiac conduction problem, who was a 55 years old woman, no cardiac disease known before. It was have come like symptom like dizziness and dyspnea with regular bradycardia during examination, and the EKG shows, sorry for the quality of the EKG, but you can see that there is a dissociation between the P waves and the QRS wave. It is a complete AV block, like you can see, but we point that the QRS were very narrow QRS with complete AV block for this young lady. So the cardiac echocardiography was normal with normal ejection fraction. The biological to see some etiology like sarcoidosis and some systemic inflammation was normal. And the next steps, the question is, what is the next step? Do we need a survey? So just a survey, no need pacemaker. DDD pacemaker for these patients. Conduction system pacemaker, CRTP, electrophysiologic exploration to see the level of the AV block, to see that if it is nodal or infra-ischian block in the conduction system. So our reflection was to see that it was patient was too young to be paced, but the permanent complete AV block is an indication class 1 to do pacemaker. And the QRS of the lady was very narrow. So if we put a lead in the apex of this lady, it lead us to electrical desynchrony. So the good option for this patient was about us conduction system pacing. But we never did this procedure in our country. We have been trying with a simulator one time, and what we did, we asked for the industry to give us the tools to perform this conduction system pacing with a PowerPoint presentation without proctor. So we tried with the output that we find in the PowerPoint presentation that you see in LIO or RIO, the position of the conduction system of the left bundle branch area. It's where we would make our lead, and that's what we did. It is our lead. Like you can see here, you have the contrast, and after the contrast, you have the lead inside the left bundle branch area. It was skewed inside the septum, interventricular septum, and this is the final position of the lead. Here it is in Aleo view. And after that, we verify we have a good anatomical position. So we see that if you have a good electrical position, that's what we verify with some value like what permits us to see that we are in the good position. It was the W aspect in V1. It is very important to have it before beginning the screwing. After we screw the lead inside the septum with the position that we had, and we have a right bundle branch apparition. So we had a good position. Anatomically, we have good output, and electrophysiologically, we have also good parameters. The left ventricle activation time was 66 milliseconds. The peak L in V1 and V6 was 27 milliseconds, and we have a pattern of right bundle branch with a QRS duration 92 milliseconds. And here you have the thresholds, the sensing and the impedance, and you see it is very, very rapid, but we have the measurement, and here you have the electrocardiogram before and after pacing. You see in the left side that you have PQRS. It was the pacing electrocardiogram, and you see that the QRS is not so wide. It is it become narrow. So we can see that we perform a good output of our left bundle branch pacing. And the left bundle branch pacing is more and more in the guidelines, and we think that we will find, we have some study, I don't have the time to develop, but we have some study that puts this conduction pacing system in the guidelines for avoiding QRS electrical desynchrony, and when the ejection function is not very low. So this is the situation. And now, in conclusion, you can say that the system conduction pacing is feasible and effective method for achieving electric resynchronization, and confirmation in prospective randomized clinical trial is necessary, and it is an excellent method to avoid artificial electrical desynchronization. Thank you very much.
Thanks a lot, Adama. I think that we have a great specialist here. And of course, we also expect the audience. S'il vous plaît, les amis, posez des questions. Please, the specialist. Et l'audience aussi, on vous attend, hein, parce que...
Very nice case. Thank you for the very comprehensive presentation. I only have one comment regarding the ECG post. Maybe I've not seen it fully, but I thought there is a monophasic RMV1. Usually what we're looking for with left bundle area pacing is sort of a narrow QRS that starts with a Q and ends with a terminal R. Was that the case in this particular case, or was it just a monophasic right bundle branch block?
There is a right bundle branch pattern in V1. What I show, I don't show V1. I show just the peripheric leads. That's why you don't see the aspect. But I quit the W aspect to the right bundle branch aspect in V1. And it was the input.
I think it was there on the monitor on one of the screens. But in any case, is it your practice that you do left bundle area pacing for all bradycardia patients now, or only patients with borderline ejection fraction, or do you use it as a substitute for CRT, like patients with very impaired ejection fraction?
Like I say, it was the first case in my country.
Okay.
And the problem was, she was a young lady. She had a narrow QRS with AV block, complete AV block, with an indication of pacing. And she had an ejection fraction that was 50%. So according to the guidelines, if the ejection fraction decrease 55, more than to 35%, we could propose conduction system pacing to lead this patient towards the indication of resynchronized therapy, cardiac resynchronized therapy. That's what guidelines say. But in this patient, it was to avoid, because I see she is too young to be pacing, and she is too young to be desynchronized, but by an apical lead position pacing.
So we are also starting our learning curve in left bundle area pacing. I'll tell you our practice here now. We've done about 30 cases. We're now comfortable in doing it in all patients with bradycardia. So we no longer put leads in the RV apex. We're postponing its use as a substitute for CRT only for failed cases, difficult CS cannulation, or when we have a strong evidence that left bundle area pacing is comparable to CRT in heart failure patients. And when we get to a level of confidence where we are confident that even in difficult cases with dilated right bundle and patients with heart failure, we can effectively pace the left bundle. So this is the current situation here in this country.
It's clear that there is not evidence that conduction system pacing will replace cardiac resynchronized therapy, but perhaps the future will tell us the truth. Thank you.
Okay, if there is no more questions from the floor, I have one question. Okay, go ahead.
Yeah. Thank you. I can ask my question in French. Alors, professeur Adamakan, je voulais donc vous féliciter pour le cas, puisqu'on en a déjà discuté. Alors, je pense que le choix de ce mode de stimulation, vous l'avez dit, c'est encore peut-être quelque chose que vous venez de commencer. Alors que la finalité, c'est quoi? C'est la tolérance, c'est l'efficience. Autrement, ma question est plutôt un peu voilée. C'est-à-dire que l'idéal, pour essayer de juger des avantages qu'apporte cette modalité de stimulation, il va peut-être falloir prendre un groupe de stimulation classique avec la sonde au niveau de l'apex et du VD, et puis cela pour essayer effectivement de voir quels sont les avantages que peut apporter cette modalité de stimulation. C'est juste la question de curiosité que j'ai tendance à te poser tout le temps. Merci.
Ouais, merci. En fait, je pense que le cas, c'est très clair. C'est-à-dire que c'est une jeune dame qui a des QRS trop fins pour être élargies par une stimulation. En fait, c'est ça qui nous a guidés vers le choix de cette stimulation. Parce que si on mettait une sonde dans l'apex, elle sera tout le temps stimulée, mais avec un QRS énorme, alors que de base, même avec sa pathologie, elle a des QRS fins. C'est ce que nous avons essayé de maintenir en mettant la sonde au niveau des systèmes de conduction naturelle. Voilà. Mais un peu le truc ici, c'est que ça veut dire qu'on peut le faire en Afrique avec la sonde classique, puisque moi, je n'ai pas utilisé une sonde dédiée. C'est une sonde normale classique de biotronique, comme eux, ils le disent, hein, que nous avons utilisé.
So, for the sake of time, we have to move to the next speaker. Thanks, Dr. Adama. Now, I have the pleasure to invite Professor Ahmed Al-Damati, Professor of Cardiology at Cairo University. And he is the chairman of the electrophysiology department at Cairo University.
Good afternoon, everyone. It's a real honor and pleasure to be here. I would like to thank Professor Magdi Abdelhamid for inviting me to this prestigious meeting, and welcome to Cairo. I'll have a quick presentation. It's rather clinical than an intervention case, and I opted to call it diagnosis at handshake. So this is about a 22-year-old male patient who is born of a third-degree consanguineous marriage. He has no risk factors for coronary artery disease. He presented by 2 attacks of syncope that is exertional within a period of 1 week. Each episode was precipitated with exertion and preceded by rapid, regular palpitations, and it was associated with sweating. His both episodes required ER visits, and he was found to be in wide complex tachycardia that was associated with hemodynamic instability and required DC cardioversion. There was nothing impressive in his cardiac examination, but to us it looked like his hands and soles are a bit rough and hyperkeratotic. That was the only thing that was remarkable at the first look. And this was his electrocardiogram. So the only feature that drew our attention was the deep T-wave inversion in the right precordial leads. As we all know, it could happen in females to have T-wave inversion up to V4. It could happen in children, but not in a 21 or 22 years old male. Having T-wave inversion up to V3 is grossly abnormal. And that was his ECG during the tachycardia. If you look closely, you will find some evidence of VA dissociation in this tachycardia, perhaps in lead AVL. It's left bundle branch block configuration wide complex tachycardia, which is important in our diagnosis, and it has superiorly directed axis. So if we have to opt where this tachycardia would be coming from, we would say probably it's coming from somewhere below or apical in the right ventricle. So at this point, what would be your most likely diagnosis? Would you think ischemic heart disease in a 22-year-old male without risk factors? Do you think it's Brugada syndrome, ARVC, or CPVT? Any idea? Anyone would like to share his opinion? Most likely diagnosis. Okay.
What?
So, well, the diagnosis that you mentioned is not here on this list, but what's here is ARVC. So when we see a tachycardia that is monomorphic with this T-wave inversion, it, in the right precordial leads, it raises a suspicion of arrhythmogenic right ventricular cardiomyopathy. So when we thought of that, we decided to have a closer look at the electrocardiogram. And if you look carefully at the junction between the QRS complex and the T waves, you would find a little ditzel that we call epsilon wave. So that's indicate fibrosis in the right ventricle, being the ventricle that's right below the right precordial leads. And if you want this to be clear, you use the Fontaine leads. So instead of using the regular limb leads, you put the limb leads at the base of the heart, at the xiphisternum, and at the apex of the heart, and you can see this ditzel very clear in lead 1, a little bit less clear in lead 2 and lead 3. And echocardiography confirmed that there is something wrong with the right ventricle. So it looks dilated, perhaps as dilated at LV or a little bit more. And when we had a CMR done, we confirmed the observation that the right ventricle is abnormal. And when MRI colleague experts looked at the free wall of the right ventricle, they could point out these microaneurysms that are pathognomonic of arrhythmogenic right ventricular cardiomyopathy. So, quick review of the task force diagnostic criteria of ARVC that was revised a few years ago. When you look at the structure of the right ventricle, you have to see akinesis or dyskinesis or aneurysms, together with either dilated ventricle or impaired ventricle. So this is the major criteria in terms of the regional dysfunction and the structural alteration seen by echo and MRI. From biopsy, you need to see myocytes replaced by fibrofatty tissue with less than 60% residual myocytes on the morphometric analysis as a major criterion, and if it's a little bit more than that, perhaps 60 to 75, it's probably a minor criterion. For repolarization abnormality, T-wave inversion in the right precordial leads in adults is considered a major criterion for ARVC. Depolarization abnormality, epsilon wave, is considered a major criterion for ARVC. In terms of the arrhythmia, if you get white complex tachycardia, VT, that's occurring from the apex of the right ventricle or the inferior wall, so the axis is superiorly directed, you know that this is sort of specific to ARVC. But if it's coming somewhere in the RVOT, this could probably be ARVC, not ARVC, and just idiopathic RVOT VT. That's why it's considered as a minor criterion if it has an inferiorly directed axis. And finally, if ARVC is somehow confirmed in a family member, whether this is proven genetically or in autopsy or some first degree relative who satisfy the diagnostic criteria for ARVC. So for our patient had perhaps 4 or 5 major criteria for ARVC, so the diagnosis was clear. You only need 2 major criteria or 1 major and 2 minor criterion to have the diagnosis of a definite ARVC. So what would be the next step in this patient? Would you give him antiarrhythmic drugs for the VT? Would you do catheter ablation, or would you put him an ICD? So in this clinical scenario, AICD is the only treatment that offers survival benefit. So this is considered the secondary prevention indication. But what are the other lines of management? So the first is the AICD. If the patient continues to have arrhythmias, you use adjunctive therapy. Medical treatment and catheter ablation are considered adjunctive therapy. They are not alone sufficient to prolong survival of your patient with ARVC. And then you go also for standard therapy for heart failure, because it is not the most common presentation, but we face some patients every now and then who do not present with arrhythmia, but they present with manifestations of heart failure. So AICD is considered class 1 indication for secondary prevention, but it can be also used as a primary prevention indication if there is LV involvement, or there is more than one family member affected, or if the patient presented with syncope, and provided that he has a reasonable chance for survival. So reasonable chance for survival in the ICD context is usually a 1 year. If there is no comorbid condition that will lead to the demise of your patient within 1 year, he is indicated for an ICD. So this is the follow-up of our patient. He had an ICD put in. Unfortunately, he developed his VT once again, and he had a successful shock, which is the good news, that restored his sinus rhythm. So you can see here the VT going on, the device detected it, and eventually it gave him a shock that restored sinus rhythm. So what else can we do to this patient if this patient kept getting VT? What we can do, beside medications, which can be used, beta blockers or amiodarone, and there are recent reports of the use of class 1C antiarrhythmic drugs, namely flecainide, for the treatment of ARVC. We can do ablation. So the classic targets for ablation are the triangle of dysplasia. So the anterior infundibulum, the RV apex, and the inferior or the diaphragmatic aspect of the right ventricle. But note that frequently you would need to go to the epicardium in these patients. So this is one of our patients who had ARVC, and we had to go epicardially. You can see that all these white areas, if the color is clear, are areas of late potentials. And on the right side of the screen, you can see little ditzels at the far end, which are the surviving myocytes within the scar that creates the re-entry for VT. Our job is to get rid of these areas of slow conduction through catheter ablation if our patient keeps getting VT. So that was the cardiac management of this patient, and we thought perhaps we would refer him to one of our dermatology colleagues to sort out his pulmoplantar hyperkeratosis. But on a closer look and on reviewing the literature, we figured that this patient probably has one of the cardiocutaneous syndromes, namely the Nexus disease. So Nexus disease is a disease that is characterized by pulmar hyperkeratosis, plantar hyperkeratosis, and woolly hair. So this part we missed, and we thought that just this is what the guy looks or prefers to do with his hair, but it's not. That is a part of the clinical syndrome, woolly hair. This is a variant of ARVC. It's characterized by what we have just mentioned. It's a recessively inherited disorder, and it was initially described and named after an island in Greece. So this was the original publication that described this group of families. It was in 1986, and again it was named after this island. So this island is sort of southeast of Greece. And the problem is with desmosomes. So the defect in the chromosome number 17 that encodes for desmoplakin and plakoglobin, which are proteins that is essential for the cell adhesion. When the cells loses the cell adhesion, what happens? The replacement fibrosis and fatty infiltrates takes over. The last thing that we did to this family is screening them. We figured a brother who had the same manifestations, so again, pulmar keratosis and the woolly hair, but his electrocardiogram was rather normal, and he did not get any events, at least till the time that we've seen this patient, so we just decided to follow him along. And with that, I conclude my case. Thank you so much.
Thank you. Just a comment, it could be also, look at my fingers, it shows you the stars or the moon, something like that. Thank you for the fantastic speech.
Ahmed, excellent case. Do we need to do genetic test for the brother who had the cutaneous manifestations but have normal electrocardiogram?
Well, I think he does have the syndrome, but he does not have any of the risk features, so he does not qualify for an ICD. And till the moment that we have seen him, because unfortunately he was lost for follow-up, he did not gain any events. So as Your Honor know, we do not have the luxury of genetic testing very much, but it would be appropriate if we screen other family members who are phenotypically negative, because they might still have the gene.
Dr. Ahmed, thank you so much. It's a very interesting case. So you go for ICD first, then ablation. So this is the normal, you go with most of your cases, or this is in special disease, you go first for ICD and then...
Very important question. Thank you, Professor Yasser. In patients with structural heart disease and sustained monomorphic VT, the mainstay of therapy still is an ICD. So we put ICD first, and then we wait, ideally speaking, after the first shock. If the patient gets a first shock, it's now appropriate time for ablation. And that was recent data that was published in the Partita study from Italy. The only situation that, as per the European guidelines, think of 2022, that we can offer catheter ablation are patients with ischemic heart disease who have rather preserved ejection fraction, so 45–50%, and who presented with monomorphic VT. There is some talk that if you do this in a high volume center with experienced operator and you get non-inducibility, so it's sort of very hard endpoints, you might be good enough without an ICD. But that is a small fraction of category. And with these guidelines, it didn't really change the practice of putting in an ICD for sustained monomorphic VT worldwide. So this is a very small fraction of patients in a highly selected centers.
Thank you very much, Ahmed. It is a very nice presentation. My question is about your experience about the ablation of the patient with dysplasia arrhythmogenic of right ventricle. You know that the myocardium is not very strong. So have you some issue about the ablation?
Well, I think I personally haven't done a lot of ARVC patients, but I wouldn't think there would be an issue because it is thin, but it is still fibrotic. So if you're careful in the epicardial puncture, because we do all these patients with endo-epi approach from the get-go. We have like 15 patients, not ARVC, but endo-epi. If you're careful with the epicardial puncture, I don't think you will face an issue even with ARVC patients.
Merci beaucoup. Je pense que thanks so much for this nice presentation, and it is a nice transition to the next and last slot of presentation. Hadi, before Hadi started and while started, un résumé rapide de ce topo. Finalement, tachycardie ventriculaire provenant du ventricule droit, sémiologie de dysplasie arythmogène du ventricule droit, avec cette dérivation particulière de Fontan qui montre l'onde epsilon. Donc, ok, dysplasie arythmogène du ventricule droit, mais il y avait un élément important du suspense, c'est cette hyperkératose. Et souvenez-vous, consanguinité, en fait, il s'agissait d'une maladie héréditaire, hyperkératose, qui est une forme particulière entraînant la dysplasie arythmogène du ventricule droit. Donc, il y a le problème cardiaque qui a été bien traité, c'est défibrillateur automatique implantable, et puis secondairement, on fait de l'ablation, hein, c'est Adama qui me l'a soufflé tout de suite, et puis après, on se rend compte quand même que it is a case of internal medicine also. And the keratosis was one of the clues of this nice presentation. Hadi, heart failure. And you have to pay attention because the boss is a worldwide specialist of heart failure.
Bonjour à tous, merci professeur Khan. Professeur, si vous me le permettez, je vais m'adresser à l'assistance en langue de Molière pour essayer de réveiller un peu tous mes collègues. Merci.
Les modérateurs peuvent se rapprocher, hein. Professeur Touré, il paraît que tu dois te rapprocher. Et tous ceux qui étaient de la modération de heart failure, ils peuvent nous... Oui, on vous fera de la place, ne vous inquiétez pas. Oui.
Merci beaucoup. Alors, nous allons commencer avec ce cas clinique qui porte sur l'insuffisance cardiaque. Donc, il s'agit de Madame KM, 26 ans, elle est ménagère, elle réside à Bobo-Dioulasso, c'est au Burkina Faso. Elle se présente pour dyspnée d'effort stade 2 à 3 de la NYHA sur une grossesse de 16 semaines d'aménorrhée. Et dans ses antécédents, on retrouve 5 avortements prématurés et une pathologie cardiaque non documentée depuis l'enfance. Donc, depuis 4 mois, la patiente présente des dyspnées d'effort d'aggravation progressive jusqu'au stade 3 de la NYHA, associée à la dyspnée, une toux productive, des palpitations sans douleur thoracique et une augmentation du volume de l'abdomen, ainsi que des membres inférieurs, le tout sur une grossesse de 16 semaines d'aménorrhée. Il faut noter que récemment, elle avait été vue par un collègue où un bilan avait été réalisé. Et ce bilan a permis de retrouver ce que je vais vous montrer tout à l'heure. Donc, je signale qu'elle était déjà sous traitement à base de furosémide, de captopril, de digoxine et d'aldactone. Et voici son ECG que je vous présente là actuellement. Donc, vous avez un rythme qui est sinusal, si vous le voyez bien. Les QRS sont assez élargis, 123 millisecondes. Un axe qui est à gauche, un bloc droit. Il faut noter aussi l'activation des cavités droites qui sont assez précoces. Un aspect QS qu'on retrouve dans le territoire inférieur et une hypertrophie ventriculaire gauche. Pardon. Alors, l'échographie cardiaque qui avait été réalisée avant qu'elle ne vienne nous voir a permis de retrouver une dilatation des 4 cavités, une fuite mitrale grade 3, une fuite tricuspide et une importante hypertension systolique pulmonaire à 95 mm de mercure. Cliniquement, lorsque nous l'examinons, nous trouverons une patiente asthénique avec des œdèmes des membres inférieurs. Elle présente également des œdèmes qui remontent jusqu'au niveau des genoux. Hémodynamiquement, la patiente elle est stable. Elle n'a pas de... la saturation en oxygène est à 95 mm de mercure en air ambiant, un pouls à 105, une pression artérielle à 135 sur 101 mm de mercure. L'examen cardiaque, les bruits du cœur sont bien perçus, ils sont irréguliers par contre, rapides, avec un B3 qui a été retrouvé, un souffle systolique mésocardiaque à irradiation multiple. À tout cela s'ajoutaient des murmures, ou du moins des râles crépitants au niveau des bases pulmonaires, une hépatomégalie avec reflux hépatojugulaire. Alors, devant cela, je voudrais demander à l'assistance, quel est votre diagnostic devant ces signes que nous avons retrouvés avec les antécédents de la patiente que j'ai donnés, les examens qui ont déjà été réalisés, évidemment une échographie qui a déjà été faite. À quoi est-ce que vous pensez? Je vous laisse réfléchir alors. Est-ce qu'on peut parler d'une cardiomyopathie du péripartum chez cette patiente? Est-ce qu'on peut parler d'une valvulopathie ou est-ce qu'il s'agit d'une cardiopathie congénitale? Donc, on a beaucoup d'éléments dans ce cas clinique. On va avancer. Donc, les différents examens dont on a besoin, je pourrais vous poser également la question, mais je vais avancer. Alors, on a refait le CG de la patiente. Elle n'était pas très différente de ce qu'elle avait au début. On lui a fait également un examen biologique. Il y avait une anémie, les TSH étaient revenus normaux. Le bilan rénal normal, il y avait la natrémie, la kaliémie, tout ça était normal. On a essayé de faire la recherche des antiphospholipides qui sont revenus négatifs vu le nombre d'avortements qu'elle a eu à faire. Alors, voici les échographies de la patiente. L'échographie a été réalisée, vous verrez, au début, vous avez d'abord l'incidence parasternale. Je vous laisse regarder. Donc, vous voyez très bien cet aspect de dilatation des 4 cavités. Son VG, il est hypokinétique. On a effectué les différentes mesures. Je vous laisse réfléchir jusqu'à présent. Une autre incidence. Alors vous allez excuser la qualité des images parce qu'on n'arrivait pas bien à dégager son apex, mais vous voyez cet aspect assez vieilli et vous voyez également qu'il existe 2 défects au niveau interventriculaire, périmembraneux et au niveau musculaire. Alors, on se retrouve devant une patiente qui présente une CIV multiple avec une fuite mitrale. Vous ne l'avez pas vu, la dernière diapositive va montrer l'écho en boucle. Là, vous pourriez voir certains détails que vous n'avez pas pu voir. Je suis désolée. Avec un aspect assez vieilli de son ventricule gauche qu'on n'arrive pas très bien à identifier, mais lorsqu'on met le Doppler suffisamment, on a comme un aspect de non-compaction du ventricule gauche, mais c'est à discuter toujours. Et le tout chez une patiente de 26 ans, enceinte de 16 semaines d'aménorrhée. Alors, dans ce cas, quel serait votre traitement médical? Quel serait également votre traitement obstétrical, c'est-à-dire la team obstétricale? Pour quel traitement est-ce que cette team-là va opter? Et quelle serait la méthode d'accouchement la plus adaptée pour cette patiente? Alors, j'ai listé ici les médicaments qu'on peut utiliser chez cette patiente. Et nous allons avancer. Donc, chez notre patient, nous avons mis sous diurétique de Lens, on a utilisé de la digoxine, on peut utiliser aussi un bêta-bloquant. On lui a mis du fer plus de l'acide folique parce qu'elle était anémiée, on ne pouvait pas faire plus que cela. Donc, c'est important aussi de voir ces différents management que le SC propose si jamais on a une patiente qui présente une pathologie cardiaque et qui aimerait être enceinte ou qui est déjà enceinte. Donc ici, il y a la checklist permettant d'évaluer le risque de la patiente. Alors, donc, notre patiente, nous avons bien jugulé son état avec les gynécologues. Donc, l'objectif de la team, c'était de faire en sorte qu'elle atteigne les 35 semaines d'aménorrhée avant de pouvoir accoucher. Mais finalement, elle a accouché au bout de 32 semaines d'aménorrhée et 5 jours d'un bébé prématuré de 1665 grammes. 2 mois après sa césarienne, elle était toujours congestive et elle allaitait son bébé au sein. Alors, devant cet état de la patiente qui a maintenant délivré, donc on voudrait vous demander quelle sera votre thérapeutique. Que feriez-vous dans ce cas-là? Donc, je signale que pour son accouchement, c'était une césarienne. Alors, ma patiente, elle a bénéficié d'un traitement diurétique qui a permis à ce qu'elle soit bien. Elle est actuellement complètement compensée. Elle est sous traitement optimisé de l'insuffisance cardiaque. Elle a les 4 fantastiques avec elle. Et là, elle me pose une question que je vais vous poser à vous également. Et elle me demande, docteur, qu'est-ce qu'on fait du trou qui est dans mon cœur? Et elle demande également à savoir si elle pourra avoir d'autres enfants. Alors, que retenir? Il faut savoir que la cardiopathie congénitale et la grossesse, c'est une réalité. L'association n'est pas contre-indiquée. La césarienne serait la voie d'abord la meilleure, je pense. Et il faut toujours essayer de se projeter par rapport à l'avenir obstétrical de ces patientes. Je vous remercie.
Bien, nous allons féliciter le docteur pour votre belle présentation. Nous vous félicitons donc pour votre belle présentation qui nous pose en réalité des problèmes très pratiques, très concrets. Vous m'entendez? Voilà. Donc, nous allons demander d'abord à l'assistance. Merci beaucoup. Nous allons d'abord demander à l'assistance. Nous remercions donc, comme je le disais tout à l'heure, docteur, pour votre très très belle présentation qui soulève en réalité des problématiques très concrètes par rapport à la gestion d'une insuffisance cardiaque chez une patiente gravide avec cardiopathie congénitale et dysfonction ventriculaire gauche. Nous allons d'abord demander à l'assistance si elle a quelques questions, quelques préoccupations particulières par rapport à cette présentation. Et nous allons sans doute après intervenir ici au niveau du panel. Professeur Ikama, je vais vous faire patienter. Nous avons une question de professeur Diarra, une deuxième question et une troisième question. Et professeur Ikama également. Donc on va commencer par professeur Diarra.
Merci, docteur Ake. Et je n'ai pas bien suivi quel était l'état de la voie pulmonaire au moment de la grossesse. Ça, c'est d'un. Après la césarienne, quel a été l'état de pression pulmonaire après l'accouchement, à distance même de l'accouchement? Quel a été l'état de pression pulmonaire? Je vous remercie.
Thank you.
Deuxième question. Nous allons recueillir les deux premières questions et demander à ce que notre oratrice réponde.
Oui, merci beaucoup. Je vais enchaîner sur la question du professeur Diarra. C'est effectivement quel est l'état de la voie pulmonaire. Et quand on voit les dimensions du défect, c'est quand même une CIV qui est large. Donc, comment est-ce qu'elle a pu tolérer cette CIV jusqu'à l'âge là? Donc, il est très important qu'on sache quel est l'état de la voie pulmonaire. Y a-t-il une sténose? Est-ce que c'était une CIV de type 4 ou comme, enfin, voilà. Merci beaucoup. Ou alors si c'est une CIV acquise après la vie?
Voilà. On vous laisse répondre aux deux premières questions. Donc, le problème est de savoir, y avait-il de l'hypertension pulmonaire ou y avait-il une sténose pulmonaire associée?
Il y avait une élévation des pressions pulmonaires. Les pressions systoliques pulmonaires étaient très élevées. Elle avait une pression systolique à 95 mm de mercure au début. Quand elle était enceinte, à 16 semaines d'aménorrhée. Et en ce moment-là, on ne voyait pas la deuxième CIV. Elle n'était pas visible au niveau musculaire. Les pressions s'égalisaient presque et on avait un shunt qui était bidirectionnel. C'est seulement après l'accouchement, les pressions systoliques au niveau pulmonaire ont baissé un tout petit peu et là, on a pu voir la deuxième CIV apparaître.
Excusez-moi, donc voie pulmonaire libre.
La voie pulmonaire, j'ai eu un petit
pas de sténose pulmonaire.
Elle n'est pas sténosée, okay. Non.
So, just one question. Eisenmenger or not Eisenmenger? Eisenmenger.
Eisenmenger.
Okay.
La troisième question.
Oui, la troisième question, s'il vous plaît. Les antécédents, dans ces antécédents, on entend qu'elle a fait 5 avortements, c'est ça? Oui. Et elle demande si elle peut avoir des enfants, d'autres enfants.
Oui.
C'est quand même bizarre de faire 5 avortements et vouloir avoir un nouvel enfant.
Elle
et
a 26 ans.
Oui, même 26 ans. Donc ça veut dire que quoi? L'instinct maternel s'est réveillé ou bien comment? En tout cas, c'était juste pour comprendre pourquoi autant enlever et maintenant vouloir des enfants. C'est bon. C'est bon. Non, ça veut dire que ce sont des fausses couches, pas avortement. Avortement, c'est volontaire, si je comprends bien. OK, très bien. La deuxième question, elle doit être sous un traitement de...
Docteur, s'il vous plaît, elle n'a pas avorté volontairement.
OK, ça change la donne alors. Oui, et elle doit être sous traitement, puisque avec une CIV à cet âge, c'est quand même bizarre que c'est à 26 ans que la CIV se manifeste. Certainement, elle devait avoir des plaintes avant, ou bien nous médecins, nous n'étions pas très attentifs, parce que cette CIV, il doit avoir un souffle, vraiment un grand souffle. Donc, c'est quand même bizarre que c'est actuellement qu'on découvre ce problème. Par rapport à la grossesse, je vous l'ai dit, certainement avec Alzheimer, la grossesse est contre-indiquée. Et puis avec les pressions systoliques pulmonaires très élevées, vraiment, ce serait des grossesses même à très haut risque. Très haut risque. Et elle doit être sous traitement, un traitement de compensation de cette dysfonction du ventricule gauche.
I have a comment here, please. Here, in English. Okay, in English, okay. Well, actually, this size of the VSD denotes that even if we see in the echo a bidirectional shunt, we should rejudge ourselves, because this is a large overriding VSD with an overriding aorta. This cannot be except an Eisenmenger disease. With the WHO classification for the heart disease with congenital heart disease and pregnancy, this is a red flag. She should not get pregnant. She got abortion because she's desaturated. I believe that her saturation definitely was in the area of 88, 85, and the risk continues after she delivers. I know that she delivered, but the thing is that her risk does not stop when she delivers. No, the risk of thrombosis and stroke increases after delivery. So she should be followed up in what we call the fourth gestational period, which is the immediate post delivery, and she should be advised to contraception totally. I know this is the precious baby, she lost 5, but still she should not get pregnant if she wants to stay alive. And she should receive, she should do, I think, I believe that you did her a pulmonary study for the reversibility of or the reactivity of the pulmonary tree. I'm not sure, did you do this, or this is the second step, I believe.
Thank you so much.
Merci. Ma préoccupation a été soulevée par les autres intervenants. Est-ce que c'est une CIV compliquée d'Alzheimer? Parce que lorsqu'on voit vos incidences parasternales, on a l'impression même que c'est une CIV par malalignement. Et puis, en cas de cavité, on a l'impression que c'est un ventricule unique même, CIV large à type ventricule unique. Maintenant, est-ce qu'il n'y a pas des sténoses périphériques qui ont protégé cette dame jusqu'à cet âge? Il n'y avait pas des sténoses un peu sévères, et puis elle avait des circulations collatérales qui l'ont aidée. Donc, faut-il pas compléter l'exploration de cette dame par un scanner pour rechercher d'autres anomalies associées? Parce que je pense que ce n'est pas une CIV simple. Merci.
Je crois qu'on va... Alors, je vais me risquer. We can call the next one, and I try to summarize what he said. No, you have another one? Yes, you have a next way. Thank you so much. But je crois que, moi, ce que j'ai compris de ce cas, c'est si on exclut effectivement une sténose au niveau de l'arbre pulmonaire, hein, les cardiopédiatres me démentiront, je pense qu'à cet âge, à 22 ans, large CIV multiple, Eisenmenger. Eisenmenger, contre-indication à la grossesse, as you said. It is forbidden, no indication, contraindication for next pregnancy. The only issue is this left ventricle. It is not a left ventricle of Eisenmenger. It means that probably we have something specific an uncompacted left ventricle or something we can call peripartum cardiomyopathy in the left ventricle, because it's not a left ventricle of hypoxemia, all these things. That's why the left ventricle suffered. But I think that we do agree, I think, that it is Eisenmenger. And for the question of the lady, no other pregnancies. It's pulmonary hypertension, you agree? Je crois que c'est un peu ça la leçon de ce très beau cas. Merci, Khadi. And the next and final case, please.
Thank you so much. Now we have the last case by Dr. Ahmed Kamal, a lecturer of cardiology at the Cardiology Department, Cairo University, and also he is one of the very active stars in heart failure.
Good evening. Today I present a case we all see in our daily practice, which is a heart failure patient with recurrent hospitalization. It is a simple case, however, we face problems during managing patients and seeing them every 2 to 3 months with recurrent hospitalization. In this presentation, we try to search for the causes of recurrent hospitalization and try to manage these causes to avoid these recurrent hospitalizations. Our patient is Mr. M.A. He is 68 years old, male patient. He's non-hypertensive for 10 years and type 2 diabetes mellitus for 5 years. He's non-ischemic heart disease with history of myocardial infarction 3 years ago, since which he became diagnosed with a heart failure with reduced ejection fraction. He also is a case of paroxysmal atrial fibrillation. Our patient was admitted to our hospital for the 3rd time in the past 6 months due to worsening shortness of breath and lower limb swelling. His symptoms began approximately 2 weeks ago with increased shortness of breath on exertion and worsening peripheral edema. That was progressed to orthopnea and paroxysmal nocturnal dyspnea with recent weight gain of 5 kilograms over the past months. His current medications was ramipril 2.5 milligram, carvedilol 6.25 milligram twice daily, spironolactone 25 milligram, furosemide 40 milligram, metformin 1000 milligram twice daily, and apixaban 5 milligram twice daily for the paroxysmal AF. The patient reports that he adhered to his medication, but he admits to missing doses of diuretics occasionally. His visual examination, his blood pressure was 145/90, heart rate 130 beats per minute irregular, AF. His slight tachypneic, 26 breaths per minute, and his oxygen saturation was 92 in room air. He has normal S1 and S2, he has pansystolic murmur over the apex, most probably mitral regurgitation, and elevated jugular venous pressure of 10 centimeters. On auscultation of the chest, he has bilateral crackles at lung bases and +2 pitting edema in the lower extremities. His ECG showed atrial fibrillation, 130 beats per minute, with left bundle branch block and the QRS complex 160 milliseconds. His complete blood picture showed microcytic anemia with hemoglobin 10.3, elevated urea and creatinine, which was mainly pre-renal with normal electrolytes. He had normal liver function test, and his NT-proBNP was elevated more than 2000 picogram per milliliter. His X-ray shows cardiomegaly and pulmonary congestion, and his echocardiogram showed dilated LV internal dimensions, ejection fraction 32%, akinetic LED territory, most probably from the old myocardial infarction, severe secondary mitral incompetence, moderate tricuspid incompetence, and high probability of pulmonary hypertension. Our primary diagnosis was it is a case of recurrent acute decompensated heart failure that was hospitalized 3 times before in the last 6 months, which is due to heart failure with reduced ejection fraction that is exacerbated by fluid overload and possible medication non-adherence. He has other contributing factors, including atrial fibrillation, which may contribute to the inadequate cardiac output, poor management of fluid status, and high sodium intake, with lack of optimization in the medical therapy in the last 6 months. Here's an important diagram that was published in 2019 by the American College of Cardiology. It elucidates the trajectory of heart failure patients from admission to discharge and even post-discharge. We have 4 checkpoints followed by 4 phases. Our first checkpoint is the admission of the patient and is followed by the acute phase, and here the important thing is the clinical decompensation. With daily trajectory check, seeing if the patient is improving or it is stalling or it is not improving and changing the medication accordingly. Then the next step is the transition to all therapies once the patient is compensated, and then The third step is the discharge, and before discharge, we should be able to keep the patient on the maximum tolerated medical therapy before discharge, and following up the patient early in the post-discharge phase, which is a very important phase, because in this phase, patients are decompensated and hospitalized again if not followed up regularly, and then the follow-up after the first discharge visit to increase the doses of the guideline-directed med therapy. So our first plan was the acute management. We admit patients to the CCU, we give IV diuretics to diurese the patients, and we monitor regularly our electrolytes and renal functions. Remember, the patient has a renal impairment from the start. And this is the algorithm we follow in our hospital. It is according to the European Society of Cardiology. We start with loop diuretics, and if not achieving adequate response, we increase the diuretic dose, or even we combine with other diuretics. If the patient has a diuretic resistance, we can offer him a renal replacement therapy. Second step is important with the medication review and optimization. And when we go to the medication the patient was on, we see that he was on Rabiprel 2.5 milligram, which is not on the optimal medical therapy, and also the carvedilol was 6.5 milligram twice daily, which is not the target. And so we should assess the need for potential medication adjustment. We should consider the guideline-directed medical therapy, including other drugs that was not introduced to the patient, like the AJANTA inhibitors and the ARNI. And here are the doses from the European Society of Cardiology guidelines. We should reach the Ramipril dose of 5 milligram twice daily, and we could also start sacubitril valsartan, starting with a dose of 50 milligram twice daily and reaching up to dose to 200 milligram twice daily, and also the carvedilol dose small, we could up titrate it reaching to 25 milligram twice daily. Here's an important study, that STRONG-HF trial, that was published in The Lancet in 2020, and it assesses the safety, tolerability, and efficacy of up-titration of guideline-directed medical therapies for acute heart failure. This is one of the largest trials in randomized patients into two groups. One group who received a rapid up-titration of guideline medical therapy while in hospitalization and early after discharge, while the other group received the standard of care. And as we can see here, their interpretations that an intensive treatment strategy of rapid up-titration of guideline-directed medication and close follow-up after an acute heart failure admission was readily accepted by patients because it reduces symptoms, improved quality of life, reduced the risk of 180 all-cause deaths or heart failure admission compared to the usual care. And now we have strong trials that show that up-titrating rapidly our medication in hospital could decrease the rehospitalization rate and the cardiovascular deaths, which is very important in our patients. The second step is treating the comorbidities, because the comorbidities may contribute to rehospitalization. Our patient has an anemia, his hemoglobin was 10.3, so we should look for iron deficiency by doing the ferritin, serum iron, and TIBC. And if we have a ferritin less than 100, or we have transferrin saturation less than 20%, we should correct it using IV carboxymaltose or dersimaltose. And here is an important study that used the ferric carboxymaltose at patients before discharge of acute heart failure. Previous studies were patients with chronic heart failure, while this study is patients with acute decompensated heart failure, and it showed that in patients with iron deficiency, left ventricular ejection fraction less than 50%, who were stabilized after an episode of acute heart failure, treatment with ferric carboxymaltose was safe, reduced risk of heart failure hospitalization, was important for us, with no apparent effect on cardiovascular death. And here's in the guidelines, said that treatment with iron supplementation with ferric carboxymaltose could reduce the risk of heart failure hospitalization class 2A. The other comorbidities, we have an atrial fibrillation, and one of the contributing factors for rehospitalization this time was the rapid atrial fibrillation, 130 beats per minute. So we should do an electrophysiology consultation and assess the need for rhythm control, either pharmacological or using catheter-based ablation of pulmonary vein isolation, which is important here, and studies showed that ablation using pulmonary vein isolation could decrease heart failure hospitalization and even mortality. Renal impairment, we do an abdominal ultrasound to check for any abnormalities in lung parenchyma. We should stop any nephrotoxic drugs and monitor the renal function test regularly and adjust the medication accordingly, especially medications affecting the renal function, for example, AJANTA inhibitors, ACE inhibitors, ARNI, etc. The most important step we missed to do in our management of these patients is the patient education. We should reinforce the importance of adherence to diuretics and monitor fluid intake. We should instruct the patient not to take too much fluids and not to take too less fluids. Too less fluids will lead to impairment in the redehydration and impairment in the renal functions, and too much fluids will lead to congestion. Second step is the dietary counseling to reduce the sodium intake. Important sodium intake. This is very important because increased sodium intake will lead to fluid retention and rehospitalization. And third step is to encourage self-monitoring of weight and symptoms, because increasing weight in a short period of time is a marker that patient will be decompensated soon. Then the discharge planning, we should follow up appointment with a specialized heart failure clinic after 1 to 2 weeks. If the patient misses this follow-up, there is a higher risk for rehospitalization in the first months. This is an important checklist that the patient should take with him before discharge. It includes all the data the patient have inside the hospital and the medications he took, the doses he is now, and when to up-titrate the doses, and if he didn't reach the maximum tolerated doses, what was the cause. This is very important for the follow-up visit, the first follow-up visit, for the clinician to up-titrate the medical treatment accordingly. The long-term management, we should do regular follow-up to monitor heart failure patient status, adjust the therapy as needed, and up-titrate guideline-directed medical therapy to the maximum tolerated doses. We should assess for potential device therapy. For example, our patient has a left bundle branch block with wide QRS complex, 160 milliseconds. However, our patient is an atrial fibrillation. So CRT in atrial fibrillation is not the best choice. If we could maintain sinus rhythm in this patient, we could assess for CRT after optimal medical therapy for 3 months. And the last step is edge-to-edge repair, transcatheter edge-to-edge repair for the severe mitral regurgitation according to the GAP criteria after putting the patient on maximum tolerated medical therapy and CRT. Thank you.
Thank you so much, Ahmed. Excellent presentation as usual, and you addressed many challenges in management of acute decompensated heart failure and treatment of comorbidities, and how to optimize medications, pre-discharge to reduce mortality and heart failure hospitalization. So I have questions. The role of vericiguat in patients with recurrent heart failure hospitalization, according to the EC 2021 heart failure guidelines. So this patient is a candidate for vericiguat to decrease heart failure hospitalization or not?
Vericiguat was first introduced in 2021 guidelines, European Society of Cardiology guidelines, and was put in class 2B if patients are still symptomatic despite our optimal medical therapy, including the 4 pillars. And results show that it can decrease heart failure hospitalization in these patients. This trial was the Victoria trial. We don't have other trials other than this trial. So it's put in the guidelines class 2B. It could be used in our patient, yes. If he is put on the optimal tolerated medical therapy, we could add the vericiguat.
The second question for our expert in electrophysiology, Professor Ahmed Al-Damati, for CRT in patients with atrial fibrillation. The outcome in AF patients the same as in sinus rhythm?
A very important question, Professor Magdi. It is indeed beneficial. It's classified as class 2A indication. The pivotal point is to keep the CRT functioning close to 100% of the time. Whether you can achieve this by rate controlling the atrial fibrillation medically, like inducing chemical AV block, or if you have to ablate the AV node electrically. So create AV block so that the heart is dependent on the pacemaker close to 100% of the time. If this is achievable, these patients do pretty well, close to patients with sinus rhythm.
So we have to consider CRT even if the patient has atrial fibrillation, as long as there is a wide QRS complex more than 130 milliseconds. Why these patients was not investigated for coronary artery disease as a potential patients for revascularization if he has significant coronary disease?
The patient has a history of myocardial infarction 3 years ago, anterior myocardial infarction, which was treated medically. His echo further shows a kinetic thin out LAD territory, and he doesn't have chest pain since then, so we didn't search for, we didn't do in coronary angiography because the patient, he is an ischemic cardiomyopathy patient. He doesn't have chest pain, he just heart failure symptoms, and by echo we don't think that the LAD territory is viable. So we decided to keep him on medical treatment as long as he don't have chest pain. Doing a coronary angio is wise decision, yes, we can do to know our anatomy, to know if there is multi-vessel disease, left main disease, we could revascularize. This is one of our options, of course.
I don't agree that these patients should not investigate. We have to rule out coronary artery disease, and unfortunately there is underuse of coronary angiography in patients hospitalized with acute decompensated heart failure. There is an evidence in the literature, there is underuse. And those patients, once stabilized, you should do coronary angiography to look for evidence of a reversible cause for myocardial ischemia contributing to acute decompensated heart failure. So coronary angiography is highly recommended in those patients. So I think we don't have more time for questions, so I'd like to ask my dear friend, Professor Abdul Khan, to close this fantastic, successful joint session between the Egyptian Society of Cardiology and our friends and colleagues from different countries in Africa. Professor Tariq, come here to close this session. First of all, I'd like to thank my dear friends and colleagues, Professor Gamila, Professor Yasser. Join us please here. Professor Gamila, Professor Yasser, Professor Hepa, Professor Ahmed Al-Damati, Dr. Ahmed Kamal, and our friends from distinguished speakers and chairperson in this session. It was a fantastic session, different challenging cases in different subspecialties. I'd like to thank all speakers and chairpersons who joined us in this successful session. So, Professor Abdul Khan. Professor Turi is the boss.
No. Just to say, to thank the whole audience for this excellent session. I would like to say just 2 or 3 words. Before coming here in Egypt, we know that Egypt was a very great country, and it is still a great country. And we were fascinated by 6 things before coming. Of course, the pharaohs and the pyramids. This is the 2 first things. The Nile and Suez Canal. This is 4th. And we were impressed by the 2 Mahdis. The old Mahdi, who is Yaqub Mahdi, and the young one, Mahdi Abdel Hamid. But we have to add a 7th thing which impressed us. We should confess that the Egyptian Cardiac Society is a very big team, and it is not by only saying very good words, but we are really very happy to be here. And we have to thank the link, which is AJANTA team, who make the link for this year. I would like all of you to thank all these 8 fantastic things I have said. Thank you very much. Thank you, AJANTA, for this fantastic session. I think that the 2nd of October 2024 should be written in golden words for us, because it is the day of the independence of India, the day of the independence of Gandhi, the day of Gandhi, and the day of the independence of Guinea too. So thank you very much again. And we expect to have a good session. Thank you.
Nos remerciements vont à l'endroit de toute l'assistance, et particulièrement à tous les intervenants, à tous les modérateurs. Nous n'allons pas nous quitter sans pour autant faire la photo de famille, mais juste avant, permettez-nous de rappeler ou alors de raconter l'histoire de l'ACME, please. Je me demande à présent, lequel des ACME a été le plus vivant? Est-ce que les Égyptiens vont laisser la place aux autres? Ou alors vous donnez le top à l'Égypte? À vous de voir. Avant de faire toujours la photo de famille, il ne faut pas passer également sans témoigner notre gratitude au président de la Société égyptienne de cardiologie. Et pour cela, j'appelle Madame Isha et Madame Ayushi, please. Professeur. Très bien, on n'en a pas fini. Il y a professeur Touré également qui demande à passer. Il a quelque chose. Je te laisse parler.
Je pense que, à votre nom à tous, à l'ensemble des collègues qui sont venus d'Afrique, je voudrais qu'on remercie notre team Chief d'AJANTA, notre ami de toujours, Mourali, qui a vraiment dépensé beaucoup d'énergie pour organiser cette rencontre. Et vraiment, c'est à votre nom à tous que nous lui remettons ce tableau. Merci beaucoup.
Merci, professeur. Merci.
Et je voudrais simplement terminer en vous disant que Professor Magdi Yacoub was so happy of this meeting that he decided that his next conference will be totally in French because he has appreciated this meeting. Did I translate clearly what you wish? I say that Professor Magdi will make the next conference totally in French. This is the map of Africa. Merci. Thank you.
Au nom des laboratoires AJANTA Pharma, nous vous remercions tous et sachez que ce cadeau nous va droit au cœur. Nous ne pouvons pas toujours terminer, comme on l'a si bien dit, on avait l'habitude de le faire. Il nous faut maintenant faire la photo de famille et on le fera avec la Société égyptienne de cardiologie. Mais après cela également, je vous inviterai pays par pays à prendre la photo dans la photothèque de AJANTA pour nous permettre au moins d'avoir ces photos comme vous l'avez vu, donc un souvenir marquant. Et après cela, j'annonce toujours le programme. Après cela, vous aurez des sacs pour le congrès que vous devez prendre pour demain, le congrès de demain. Donc, vous aurez vos sacs et vos badges à prendre à l'entrée. Et après cela, s'il vous plaît, 17h30 pour l'inoubliable croisière dans le Nil, toujours en blanc. Donc, pour l'instant, la photo de famille, s'il vous plaît. Je vous invite tous à venir nous rejoindre sur le stade pour qu'on puisse faire la photo de famille.